Good July morning, everybody. It is July 11th, 2025, and this is Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. I am your host, Lisa Selberg, and I am joined this week with Dr. Martin Maron, Marty to those of us who've known him for more than 2 decades, or maybe less. So, Marty, how is everything up at Leahy today?
Good. All good. Good to see you. Everything's good here. Thank you.
Glad to hear. Glad to hear. So, we have a couple of updates from the trenches here at the HCMA.
Yeah.
For those of you who have been following Declan's journey, we know that he had his myectomy and ran into complications. Declan is a 6-year-old little boy from LA whose family traveled to Mayo Clinic for surgery and ICD placement at the age of 6. He's a 6-year-old little boy. Unfortunately, he ran into complications. His heart is very stiff and very thick, and he's on ECMO right now, awaiting transplant. We're going to be kind of organizing something because we have 2 families at Mayo right now with young ones who have had some challenging journeys. So stay tuned next week for some plans from us to brighten their day a little bit. So we'll tell you how you can get involved with that. So that's what's going on in that part of the world today. I also want to let everybody know I haven't updated because I haven't done a podcast since I visited Indiana. I was able to meet Esther Grant Rivas's husband and children when we did our meet and greet in Indiana. And I just want to let you know that the family sends their absolute thanks and respect for all of the condolence wishes sent to their beloved Esther. Meeting her children was quite something, and her husband, Herbert, really stood up as a caregiver in some really tough situations. And we just really need to remember that our community extends sometimes beyond the life of the big-hearted person in the family. And we really need to support our families when they deal with loss. So it was good to be able to meet her children and her husband. Just wish I had the chance to meet Esther. Marty, just so you know, Esther is a young lady who had to undergo a 3rd heart transplant after rejecting 2 in different ways. She passed away at the age of 36 last month. And the entire community was rallying behind her for her 1st and her 2nd and her 3rd transplant. And there's only so much the human body can take. So just know that the family is really appreciative of all of the support that they have received from the community. So it's been a rough couple of weeks here with some complicated families and good in other ways, which I have some projects we're working on that we're going to talk about a little bit later in the year. But today, theme of the month is kind of talking about centers of excellence. And we use that term quite loosely here. We all kind of know what it means. And Marty, you and I kind of helped define what a modern HCM center of excellence is on that auspicious day. I think it was 2003 when Jim Udelson approached me at ACC and said, I think we want to build something at Tufts with this new Maron character. What do you think? I'm like, well, let's figure this out. So it's been a long ride since then. What are some of your reflections over what it was and what it's turned into?
I think that first, I think let's just first call it what it is. I think you deserve also a huge amount of credit here, and maybe in fact one of the most important initiatives that you and the whole HCMA leadership organization, have really done. If you sort of point to some of the major initiatives over the last 10, 15 years, one of those has been this idea of the HCM Center of Excellence, that idea, which really did originate, with you, particularly as a concept of how to sort of start to define it and how to execute it, and implement it, from coast to coast, literally. And we can get into more about sort of what it looks like in a second. But I mean, I just want to first say that initiative, at least in my view, may be one of the most important things that has happened to this community over the last two or so decades, because it really has helped to, I say that because it really has, more than almost anything else, helped to advance the care in a certain direction that may not have happened otherwise.
I agree. I don't take credit for things. I don't feel comfortable with that typically, but in this particular case, the knowledge,
Yeah.
let's go to core concepts. Like,
Yeah.
why did we feel that we needed to,
Yeah. Let's talk
as an
about
organization, structure?
that. Yeah.
And it starts personally.
Right.
My sister was harmed because of lack of knowledge of her disease state,
Right.
which caused mismanagement, which led to her death at the age of 36, which was completely avoidable. Lori did not have to die that day.
Right.
And had we had a better structure of program with deeper knowledge and understanding of disease, I believe she could have survived it. So that concept led me to wanting to find the people who knew the answers. So I found some other guy named Maron, you might know him.
Right.
And I looked at not only the body of work, but the style of the delivery of medicine that was existing at that point at the NIH intramural program, and a couple of other programs that seemed to understand, like Cleveland Clinic and then later Mayo Clinic. They had some really good structural components that help patients not fall through the cracks. They still needed some work. Then the NIH went down and wasn't there anymore. And your dad was at Minneapolis Heart, and he had his structured program, and it had some really good foundational components. And I'm like, how do we build this more? And we started to meet physicians, and we started to talk about what part of their actual career path included HCM versus other forms of cardiology, and how much they would prefer to specialize in HCM. And we started to build some passion around the disease and the unanswered questions, which was kind of the underpinning from my side of it. How do you see it?
Yeah, I mean, I think I see it, a number of different ways, including what you just said. I mean, I think that, just to sort of back up, I mean, one of the reasons, why, I guess one of the first fundamental questions is, why do we need centers of excellence in this disease?
Mm-hmm. Yeah.
And, obviously we have to sort of answer that. And we did answer that, obviously 20 some years ago, because you implemented it because of, I think, first and foremost, the idea that with a relatively uncommon condition like HCM, that is complex disease itself, but is relatively uncommon, that there is a enormous amount of value to patients to have physicians, cardiologists who have seen a lot of the disease, that understand the disease in a way that they can translate to individual patients to improve care. So in other words, in order to deliver the best care, it really has to come from physicians that are seeing HCM, because HCM is a disease in which there is a huge, we've talked about this in multiple different podcasts, it's a huge spectrum. And so, to really get, proficient at being able to manage a disease like this, and this stands therefore in contrast to other non-HCM cardiovascular diseases, you really have to be seeing the patients a lot in order to develop the kind of judgment, intuition, and expertise that translates into really good care. And that can only really be done in the construct of an HCM center. Okay. So I think first and foremost, when I think about center of excellence, I think about that principle really providing the most value in a way out of the center model. Okay. Of course, there's also lots of other things that are good that come out of the center model too. The opportunity with centers to be able to deliver education to patients in a certain kind of way that other people cannot do, and also, of course, the opportunity within those centers to be able to deliver at the highest level the procedural type of expertise that is necessary here as well. And so all of those things sort of together, in my mind, were the reason to start the centers, but also kind of confirm now 20 some years later why that was so important, because I do think if you look at it at this point, there's no question that the 40, 50, 60 centers that exist today are delivering care to patients in a way that we would not have had if that hadn't been done.
So the count as of today is 56, with an application in our board minutes for a couple of new partner potentials, and another site visit later this summer, and 2 more may be added before the end of the year after that.
Yeah.
So we should be at about 60 programs by year end.
Right.
And they're not all the same model of care. And that's a really critical point to bring up. They are not all equal, but they have capacity to handle to a certain level of care and expertise. Some of them do not have transplant. Some of them have referral arrangements for surgery, and that's fine. You don't have to have the surgery right there, as long as they're willing to get you to somebody who knows how to do the surgery safely and gives you best outcomes. That's part of the critical evaluation.
Exactly.
And when they grow large enough, then their surgeons will learn so that they can stay up on their skills. So it takes some time to evolve.
That's right.
And the number that really has come to the surface, it's actually interesting when you, if you ever read Malcolm Gladwell, he wrote a book called 10,000 Hours, and it turns out that 10,000 hours of HCM care happens in about 600 patients. So by the time you do all the imaging review and all the case management and you see 600 patients, you've got 10,000 hours in.
Yep.
And that's about the level of experience somebody needs to truly become an expert in a field.
Yep.
So there's some centers that are only at 200 or 300 patients right now. They're learning, they're organized, they have infrastructure. Are they the best programs in the country? No, but they're developing and they can provide safe care to patients. And as we've grown our Center of Excellence model, we started to ask more questions about representation, about the staff. We want to make sure that the staff represents the community they serve in terms of the ethnic makeup of the team and the levels of experience, early career, late career. You want a homogeneous mix of that. You want to make sure you've got the best imaging protocols. You want to make sure that you've got the right equipment, infrastructure, facilities, and know how to process a lot of patients effectively in a visit that lasts a day or two, not that you have to keep coming back for, because that makes it easier for the patient. So all of these elements, some of them are hard values.
Mm-hmm.
Who was taught where? What is, what have you published? What do you know? What have your experience been? And some of it's logistical.
Right.
And when you have really good clinical knowledge and bad logistics, it's not a good patient experience. So we try to work with programs to develop that good logistical flow into that great clinical care, and then bridging that to the home doctor and that home part of care that only a Center of Excellence can be a party to. And I'd kind of like you to discuss how important it is to have good communication with the home cardiologist or the home physician on these patients as well, and how they're really part of the success of centers when done properly.
Yeah, no question. I mean, I think that is also a great point, that the centers, generally can function in a way to communicate with the patient's, primary cardiologist, that they're going to be maybe seeing even more than the centers because of certain geographical distances, other limitations. And so the opportunity for the sort of this degree of expertise that you're getting from the centers and those cardiologists at the centers being able to communicate the kind of care plan and also to troubleshoot if things come up for patients locally is so valuable here, and I think is really a huge resource for the local cardiologist too, to be able to have the opportunity for those patients to be managed by an HCM expert, but also to call on that HCM expert when they need to, if there's certain things that come up, and they often do come up for those patients locally. So this exchange of and this what is really a collaboration between the HCM experts and the general cardiologist is part of the success of the optimal care that's been part of the centers for sure.
So, as somebody who has the unique experience of building more than one program,
3.
yeah, I was going to let you drop numbers.
I'm not counting. I think I'm gonna, yeah,
Three programs.
yeah, yeah.
What are some of the things that people don't think about when they think about going to a center? There's a lot of logistics. There's a lot of moving parts, and it requires some skill set to manage.
Yeah.
What's that part of this whole process like? We don't
Well,
talk about it much.
yeah, I mean, there's a lot of elements to that. I think, I think one of the things I've noticed about that maybe over the years is that, I think to, maybe this is a little bit off track for the audience, but I mean, for those that are part of these new centers, I mean, I think one of the really important key things is that you have to have kind of buy-in and support from your institutional leadership for the creation of the center, because the center has to function a certain way. Patients have to be sort of funneled to the center within the institution so that there's consistency of care for patients with HCM being seen at that institution. And so they really should be sort of, almost all of them should be seen within the HCM care team within the center. And so to do that, you have to have support and buy-in from the institute's leadership team as well to really function at the level on all cylinders, so to speak, that you need to for this kind of thing. And I've seen where that if that doesn't work, there's conflict, and the center can't really live up to logistically and operationally the goals that it really needs, because there's fracture there. There isn't the kind of buy-in that you need to make it work the way it is. So I think that's really one of the fundamental, really important principles here.
I love that you brought that up, because I don't talk publicly a lot about the site visit process. People know we do them. They don't know what happens
Yeah.
behind closed doors. One of the things that happens, which some people might be surprised with, we meet with the hospital's CEO, with chief of finance. We meet with the division chiefs of cardiology. Sometimes maternal fetal medicine shows up, the chief of that department,
Right.
because they're interested in what we're doing, because nobody else asks for them in
Right.
cardiology. We're trying to bring them in. So we're meeting with senior leadership at the hospital system, and we're there also to support the development and appointment of resources to this center. So
Right.
we get to explain to the leadership of the hospital system, here's this patient community, here's what's already diagnosed in your area, here's what's missing. There's all of these unhoused people. How do we get them into this program and make sure you can treat them well? So that means we're going for staffing commitments as they grow from
Yep.
the minute we're starting to talk with them.
Right.
And this has evolved over time. Like when we first worked on Tufts, and I came up for a ribbon cutting, and then we all went out to dinner. Remember those days?
Yeah.
It was so calm.
Yeah.
It was so mellow. So we did that back then, but we've evolved, and we're asking for more information, and we're setting up more of the business model so they understand when they're going to need to develop more resources for this program. And when they get to certain patient counts, that they need to consider adding another nurse practitioner or another physician, or they're going to have to own their own magnet. So they need their own MRI machine or whatever they might need when they get to certain points. We
Right.
help them predict their growth.
That's right.
And by doing that, we set up these programs not only to open, but to build and to become sustainable models.
Yeah.
A lot of programs early on, we had a couple of them that opened and then they just kind of dissolved real fast. And we're like, okay, that model's not working. Because what good does it do to house you with somebody who, when that guy decides he wants to move across country, the program's gone.
Right.
So you need a strong, sustainable program that lives beyond an individual physician and can be transferred down the line as people get to that lovely point of retirement, which is an okay word. So sustainability modeling needs to be encouraged into the program early, not late.
Yeah.
And we're currently working through a number of programs that are in staff transition because the original director is retiring.
Right.
And I might have a little bit of jealousy, but that's okay. We were all hoping to build something that lives beyond ourselves. I think most of us are trying to do that. And these programs critically are important to stay there for the families. They will evolve over time, they will change, and that's okay.
Yep.
And that's the structure of the program. There's a lot of elements that go behind the actual review of the program, the report to the board, the questions from the board, the
Right.
back and forth that goes on. And our relationship isn't financial. We don't really ask for a lot of money. I think our current COE review fee is $5,000 to cover our expenses and whatnot, and then it's $3,500 a year per center, which
Right.
is pennies, and it's mostly for the work that we do to provide resources to that center. So some people question, like, well, of course you want the centers of excellence. You must get money out of it. $3,500 a year per center, and we send a lot of printed material out. It's not a profit center for HCMA. We make more of our money on grants and projects
Right.
than center of excellence development. We don't want to make money there. That's not the point. The
Mhm.
point is to build these strong programs so people are safe.
Right.
Families are kept whole, and we minimize the burden of disease from HCM. So that's what I've spent the last 30 years of my life doing.
Well, that's a living legacy. I mean, that itself, I mean, is a legacy. You just talked about how important a legacy is for all of us. We want to all kind of aspire to try to leave that. And as I've said, many times, including earlier today, that this the centers of excellence is a legacy for sure that will hopefully last forever.
I'm hoping so. So we designated it as HCMA recognized centers of excellence for a reason. It was very specific language.
Yeah.
It's not certification. It's not accreditation. Those are different legal terms. We recognize the elements of a program that are important not only for the clinical management of HCM, but for the patient experience going through the system and working with the system long term.
Right.
So we recognize those components, and we recognize that there are human beings behind each and every part of this process.
Right.
And that sometimes people don't always hit the mark. And if they don't, we have open and honest communication. There's a break here in the system. And we jump in and we talk to programs about little problems, communication problems, billing problems, things on that level where we can help smooth things out and stop the problems from consistently happening.
Right.
So that's our role. And we want to support our team members that are on the clinical side. Guys, I don't know if you know this or not. Patients, I'm talking to patients. This is not typical cardiology practice. These guys work really hard. The docs, the nurses, the admins, they're into the harder part of cardiology. If they wanted an easier job, there's easier puzzles to solve. HCM is a complex puzzle. So you'll notice that our key physicians and opinion leaders are really critical thinkers. They're puzzle solvers. They're looking for the missing pieces. And that's what makes a great HCM doc. And that's hard work. It's not just going to work every day, seeing a patient, filling out some files, and going home. You're stuck in their anatomy. Why are they feeling the way they're feeling? Why isn't this element working? What else can we try? What else is in the toolbox? Who else on the team do I need to bring in? It's complex work. And I sit in awe of these teams every day. I get to work with them every day. I get to see what they do, but it's not easy work. And if you think they don't take it home with them, you don't know these guys very well. So sorry, I had to shine you guys up a little bit there, but
that was nice. I think we all appreciate that. That was very nice. Thank you.
Well, it's important because, we are, I'm going to get a little metaphysical. Lisa's been spending time in the metaphysical lately. We are all just trying to get through this thing together, and we each have our own role in it. And it's not always easy, and it's not always clear. And sometimes it's scary, and it's scary to be on all sides of this. Clinician looking to say, I'm not sure what to do. Patient saying, I'm not sure what to do. And we have to come to decisions together sometimes. And that makes HCM a bit more unique than some other disease states where here's the treatment. This is what you do. It's very easy. Marty, is HCM easy?
No, I would not use that word here at all. no, challenging, for sure, but not easy. No, we would never say that.
And that is why centers of excellence are important. You
That's
need a
right.
team.
That's right.
I tease people behind the scenes when I'm doing the site visit that when you're doing your team meetings, now some people meet weekly, some meet every other week, some meet once a month, depending upon the volume of their program.
Right.
But when you meet, you got to be able to close the door and fight it out with your friends. You got to fight for your positions. You got to negotiate what you think is best and why. And you have to be able to communicate at a very high level to be respectful of everybody's input and to come to a collective agreement on what everybody believes is in the best interest of this particular patient or family.
That's right.
And that makes it difficult. So I want you all to just take your own workspace and the people you work with every day. And imagine you have to have really deep debates with them every day on left or right, up or down. And then everybody be cool with everybody afterwards, right? Because you got to work together. That is a challenge of very smart people to be able to do that well. And I really stand in awe of these teams that are able to do that and argue their points and come up with the collective best and move forward and document and publish and teach simultaneously. So that is why I feel HCMA recognized centers of excellence are awesome and why we're going to be building more. But they're going to be different as they grow because the institutions are just getting a little bit smaller in some cases. So the population is going to be a little different.
Hmm.
Healthcare is changing.
Mm-hmm.
Rural programs are going to maybe look a little different because hospitals are going to be closing. And we are paying attention and looking for alternative pathways to get people to care. One of which I'll bring up is the Lori Fund. If you live in an area that doesn't have a high volume center of excellence and you need consult, you need a therapy, you need treatment, you may qualify if you financially qualify for the Lori Fund. You can apply at any time. If you have the resources and you want to donate, we'll give up to about $600 per person per year to travel to a center. Trains, planes, automobiles, food on the road, whatever they need. We want to make it easier and more accessible to patients. So we hope that if you can give, you do, and if you need, you can take. It's here for you. It is named after my sister, who was the first one in our family. Well, not the first one, but the one that brought me to attention and made me change my life and become an advocate and literally change everything about my life. But
Hmm.
I love her for it, even
Hmm.
though it's been a chaotic journey. From pain can come good things. And that's where all this originates from.
Right.
So it is almost top of the hour, and Marty has to get off to a different topic. Marty, is there anything else going on in the space of HCM we should be aware of for the month of July, other than to stay really well hydrated?
Well, I'll just say that that we didn't talk about any kind of research updates, but or what may be coming up. But I'll mention that right now if we have a second.
Please do.
Yeah, I think there's going to be for the patients there's going to be an important study that was completed. Some of you may have been part of it in terms of participation. That's going to be presented in a meeting at the end of August in Europe. It's called the Maple HCM phase 3 study. So it's a big phase 3 study. Means that it's a study where you're looking in a large number of HCM patients at a certain kind of efficacy endpoint. And the study that I'm talking about was about looking at so the question is, remember, we use beta blockers all the time as first line therapy to treat symptoms related to obstructive HCM. And so what this study is looking at was whether or not it would be advantageous to start with monotherapy, single therapy, with instead of beta blocker, cardiac myosin inhibitor, aficamten here in this case, the study. And so it's a study that really, because of what it's asking, which is it better or more advantageous in terms of how patients will feel and function, as well as safe, to start with a myosin inhibitor, aficamten, as your treatment for symptomatic obstructive HCM versus a beta blocker. Okay. And so that study, the results of that study, are, as I said, are going to be presented in full at a meeting at the end of August. And I'm just giving everybody kind of just heads up, because I think the results of that study will have the potential impact, depending on what they look like, have the potential impact to be a paradigm changer, possibly, for how we look at therapy for symptomatic obstructive HCM. Okay. And will also give us perhaps a lot of additional insights into beta blockers themselves as a treatment in HCM, because they haven't actually, just for the patients, they haven't really been studied actually nearly as extensively as we would study a new drug today, because they're very old and we've been using them forever. But we actually haven't had a lot of studies directly looking at the efficacy and safety of beta blockers at all. Okay. And so this study
Isn't that interesting?
Yeah.
It's the thing we go to. It's the thing everybody gets dumped onto, and we really don't have any data in HCM. This is amazing that we're doing this now. So I really appreciate Cyto for doing that in this trial design.
Yeah, it's a very unique study. It's the first time ever, really, that we've had a head-to-head kind of comparison of drug treatments in HCM. That's happened a lot in obviously in other cardiovascular diseases, but not in HCM. So it's very unique. And I think we're going to learn a lot about treatment for obstructive HCM. So I'll conclude on that and be on the lookout for that.
We will be publishing. I might even go live from Europe. I'll be in Madrid, Spain for that data. So if there's good Wi-Fi, we might even go live. We'll see what happens when we get over there.
We should connect and try to, talk
maybe
about.
Maybe even if we can't do it live, maybe shortly after we'll do a little debrief with everybody. We can jump on find a corner and find a computer. So we've got that coming up. And then Marty and I are going to be talking to you more about another trial coming up for the non-obstructed population.
Yes.
From a company called Imbria. You want to talk a little bit about that?
Yeah, I do. I actually, well, let's
gotta get to another one.
Yeah, because I got to roll here right now. So
we're going to do a wrap up of the phase 2 trial data that you presented at ACC last year. So we're going to bring that back to the community. And in the fall, we'll be opening up a clinical trial for those with non-obstructed HCM. So for those who were in Odyssey and were pushed out of that trial because of the closure, there's going to be another opportunity for a non-obstructive trial coming up. Marty had to ditch, so I'm going to wrap up with that one. I wish you all a happy weekend. I hope you all enjoy some sun and fun this summer weekend, or if you're from down under, not so summery there right now. But that's all I've got today, ladies and gents. Thank you to our sponsors and to the community for always supporting each other. Stay tuned and we'll talk soon. Bye-bye.